for Healthcare Innovation's Lunchtime Learning Series. My name is Carolyn Shimon. I work here at the Georgian Fate Center for Healthcare Innovation as a patient and public engagement lead. So I'd like to welcome everyone here in the room, but also welcome all of our friends who are joining us via webinar as well. And today we're going to be talking about incorporating a trauma-informed intersectional analysis in patient engagement and health research. Don't worry if you're like, what? Because we're going to go through it together. So no worries. I'd like to start off today by acknowledging that we are gathered here on Treaty 1 land, home of the Anishinaabe, Cree, Oji Cree, Dakota, and Dene people, and homeland of the Métis Nation. And so in coming together today, we respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past. We recognize the ongoing present-day colonial violence that is faced by Indigenous peoples within healthcare systems, education systems, justice, child welfare, government systems, and we dedicate ourselves into moving forward in a spirit of reconciliation and partnership and collaboration. And when we're talking about patient-public engagement in health research, it is in fact Indigenous research methodologies that are at the forefront. And we really need to look at Indigenous scholars, researchers, and communities as well, and all the amazing work being done. Today, to give you a little bit of an overview, sorry about my voice there, to give you a little bit of an overview about what we're going to be talking about, we're first just going to go over briefly what the current context of patient-public engagement and health research is, how the concept of patient engagement can be problematic. We then are going to talk about reframing the goal of patient-public engagement and health research, some of the key concepts with regards to a trauma-informed intersectional analysis, and then what would it actually look like at a practical level. And then at the end, there'll be time for questions, both here in the room, but also definitely feel free to send questions as well, our friends, to the webinar. So first of all, anyone who's seen me talk before knows that I love this quote. It's a quote by one of my favorite theorists. She's a post-structuralist queer theorist by the name of Judith Butler. And typically, actually, the language she uses is typically not as accessible, but this is a very straightforward point. She says, let's face it, we're undone by each other, and if we're not, we're missing something. If we're not, we're missing something. I actually have this quote in my cubicle on my wall as a reminder that as human beings, we are complex, and we inhabit many different social locations. And when we come together, we all, as individuals, whether we're health researchers, whether we're patient-public partners, community members, we all bring our own political, cultural, economic, subjective, and experiential knowledges to the table. So what does that mean? It means it can be messy at times. It can be uncomfortable. It can be complicated. But another researcher that I love, Brené Brown, says, there is no innovation without vulnerability. And that's something we need to remind. And I know for myself, when I think about engagement, I have to remind myself over and over again. We always joke in my office, if you're not uncomfortable, you're not doing it right. So always think about this when you're engaging, that uncomfortable is okay, because that means maybe we're creating inclusive and safe spaces where we can actually challenge each other, challenge our ideas, and renegotiate power imbalances, those types of things. So it's always really important to think about these. So here in the current context in Canada, we have the Strategy for Patient-Oriented Research, and that's a national initiative. The Center for Healthcare Innovation here is actually the Manitoba support unit for the Strategy for Patient-Oriented Research. The Strategy for Patient-Oriented Research defines patient-oriented research as kind of a continuum of research that has 5 elements. First of all, it engages patients as partners. Second, it focuses on patient-identified priorities. Third, it improves patient outcomes. Fourth, it's conducted by multidisciplinary teams in partnership with relevant stakeholders. And finally, it aims to apply the knowledge that's being generated to improve healthcare systems and practices. Now, if you notice, as I always say, the "and" is capitalized and underlined for a reason. It is all of these components that make patient-oriented research. Sometimes I have people come to me say, I do patient-oriented research, I do research that improves patient outcomes. But that's a lot of research. What defines patient-oriented research is that you're actually engaging patient partners in the research decision making about the process, in identifying priorities, and so on. And the strategy for patient-oriented research defines patient and public engagement as the meaningful and active involvement of patients in the governance of research. So that means people with lived experience, caregivers, communities sitting on the research team at the steering level, at every level of governance. In the priority setting of research, so actual communities, patients, members of the public, setting the priority for research. In the conducting of research, that means we're involving people in actually doing the research. So we have patient community co-researchers, we have peer researchers, and finally in the knowledge translation of research. So how are we going to share the research findings and co-developing these methods? In the UK, it's called Involve. It's been around a little bit longer, the organization that's quite similar to Strategy for Patient-Oriented Research. And they actually say public involvement in research. And they define it as research that's carried out with or by members of the public rather than to, about, or for them. So that's another way that you can look at it. For me, whenever I talk to health researchers, I like to really emphasize that it's about people, informal caregivers, communities with lived experience of health issues, having a say in decision-making about the research process. That's really what kind of divides us, which divides kind of participant versus partner, right? Because partner means that people are actually sharing in research decision-making about the process. And the core belief that kind of underlies a lot of the strategy for patient-oriented research and this idea is that it's going to help, by involving people with lived experience, it's going to help improve health outcomes, it's going to enhance the healthcare system, it's going to increase the quality, the appropriateness, the acceptability, the transparency and relevance of research, and it's going to ensure that health research actually addresses issues of importance to people with lived experience of a health issue. And so we can involve people with lived experience in a number of ways to help identify research priorities that actually have meaning to people with lived experience. We can involve communities in helping shape and clarify the research question, or ensure that some of the methods or design that are being proposed for the study are actually appropriate, acceptable, sensitive to the real world context of people living with a health issue. Also helping to ensure research uses outcomes that have true meaning for people and communities. Sometimes people with lived experience are engaged in order to ensure that language and content of the information that's being provided to participants in studies are appropriate and accessible. So co-developing surveys, looking at consent forms, co-developing protocols and scripts that we might use. And then that in turn, a lot of times helps to increase participation and recruitment in a research study. Also, one of the biggest things we always find is that when you start to engage people with lived experience, researchers end up finding a huge kind of new areas, new research topics that they may not have thought about before. And people with lived experience are great, can be wonderful to engage around interpreting some of the research findings from their own perspective. And of course, ensuring that research actually reflects the concerns and the interests and the values of the public, and that money and resources are actually used efficiently. Oftentimes when we talk about patient and public engagement, it exists on a spectrum. So at the lowest level of engagement, we kind of have the consultation level. That means we are obtaining feedback and suggestions around health research decisions, but the decision-making power still is with the researcher. When we move to collaboration, this means shared decision-making between communities and researchers. And then when we come to patient and public directed, this actually means patients, caregivers, communities actively manage and direct the research project. Researchers' job then is to provide advice and even sometimes conduct the research, but under the management of the community. So way back when, in 2015, the center had this workshop in Manitoba where they brought together health researchers as well as people with lived experience, healthcare consumer organizations, community organizations, healthcare professionals, decision makers, policy makers. Everybody came together to have a conversation about patient and public engagement in Manitoba. What is the current context? What are some of the facilitators? What are some of the barriers? And the first part of the day was pretty good. We had the World Cafe. We had lots of great discussion. And then we came to the uncomfortable moment. That moment we were talking about with Judith Butler's quote at the beginning. There was disagreement. Emotions ran high. There was, people started talking about the terminology that was being used, that it wasn't inclusive, that there were voices missing from the idea of patient-public engagement, that it really looked like more of a top-down approach versus an upstream approach, because it wasn't communities necessarily running it, but it was institutions. So there was a lot of conversation around this, and this was where everything got a little bit complicated and messy, and it was tough. And so what came out of all of this is that the concept of patient and public engagement can be pretty problematic. And this is something that had been discussed at a number of different levels. What I often heard, even at the national level, was, it's the terminology, patient, that's not accessible to everyone. What we started realizing was it wasn't just the terminology, it was the way we were actually conceptualizing patient and public engagement. Mainly because it negates very real kind of complexities and context of people's lives. So we begin to start to kind of challenge and disrupt the identity of researcher by complicating the idea about who has expertise and who has knowledge in engagement. What we continue to do is essentialize the identity of patient. And what we started realizing was, quite soon after that, was that approaches and methodologies that are created based upon a definition of patients as this kind of homogenous group of people that researchers just need to go and engage, really denies the reality that individuals' economic, political, cultural, subjective, and experiential lives intersect in really intricate and multifarious ways. And oftentimes it excludes a lot of different voices. It excludes people who don't identify as patients because of, there are people who are unable to access the healthcare system because of geography or systemic barriers. And by systemic barriers, I mean things like colonialism, racism, sexism, homophobia, transphobia, ableism, sizeism, all of these things, classism as well. It also excludes people living with mental health or substance use issues, where taking up the label of patient can sometimes be associated with stigma. And then also it excludes people who refuse to engage or prematurely exit because of unresponsive or disrespectful care. And then finally, it also excludes voices of people, sometimes people living with disabilities who perhaps have been continuously medicalized within the healthcare system simply for being differently abled and do not relate to that identity. And the biggest piece of the puzzle is that we know we have robust evidence of the existence of a social gradient in health. And this means social and economic conditions and their effect on people's lives determine their risk of illness, the actions they're able to take in order to prevent themselves from becoming ill, and then treating illness when it does occur. We've seen, so for example, we know evidence shows that cardiovascular disease mortality in Canada is highest among those in the lowest income group. And as income increases, we know that mortality rate decreases. And if we were to look at the lowest income group, so under 20,000, we know certain populations that experience systemic racism and colonialism have a higher rate of cardiovascular disease. So we know there's intersections that start to occur. So the premise, what does this have to do with patient engagement? What does this all mean? Well, it means that patient engagement strategies that don't consider the following 2 points. So first of all, that simultaneous interactions between different social categories. So when I talk about social categories that make up social identity, things that I mean are gender identity, gender expression, race, ethnicity, culture, indigeneity, sexuality, religion, immigrant status, age, all of these different pieces together. If we don't simultaneously look at the interaction between these things and the impact of systems and processes of oppression and domination, so racism, colonialism, sexism, transphobia, all of these pieces, we actually exclude the involvement of individuals who oftentimes carry the greatest burden of illness. So the voices that are already traditionally not being engaged in health research. And even a couple of years ago, I was at a presentation with Simon Denegri, who's the chair of Involve in the UK, which much of our North American SCORE and the Patient-Centered Outcomes Research Institute in the US as well. A lot of these initiatives are based off of Involve in the UK, which has been around for a long time. Simon Denegri said in this presentation, well, what we've realized is that patient and public engagement is predominantly a white middle class activity. And in the UK, we're only now starting to look at Black and new immigrant population. So what that means is, if we're following this lead, we need to start thinking about how we can all voices. And what it means is thinking about how we've thought about the central goal of patient and public engagement. So there's been a shift over years. So if you look back at some of the original roots of patient and public engagement, if you look at HIV/AIDS activism within the 80s, the disability movement that coined the phrase "nothing about us without us," it grew out of a sense of democratic purpose, that people who are affected by research have a right to have a say in how, in what, and how publicly funded research is being carried out. But there's been this shift over time. So the first shift was that we started conceptualizing involvement of patients in health research as a means towards better personal health decision making. So if we involve the public, it'll increase their understanding of health research, which in turn will strengthen the ability to make good health decisions for themselves and their families. And then we did another shift. Where the ultimate goal of public involvement in health became about enhancing research. So the involvement of patients in health research improves the quality, the transparency, the relevance, the accountability of research. But in this shift in thought and conceptualization, we moved it to a top-down approach that centers on the primacy of researchers' needs versus community needs. In turn, what happens is we started replicating and reproducing already existing inequalities by privileging certain voices. So mainly white, middle class, well-educated people who, first of all, have relatively fair access to healthcare systems, who can navigate the system with comparative ease and feel comfortable with identifying as patients over other voices. So how do we move to a place that brings it back to it? First of all, it's a matter of reframing it from a health equity and social justice lens, which is much like what we hear about community participatory research action, only we're going to further expand when we're talking about it, where participatory frameworks often leave off by addressing kind of the impact of complex interplay between identity formation and systems of power and oppression, both for researchers and for patient partners. So actually investigating and exploring that piece of the puzzle. We're also going to be using trauma-informed as well. And what happens when we start to integrate some of these approaches is that we start to expose spaces of potential resistance and renegotiation of power within the intersubjective relationships between researchers and partners. So we start changing things. So that's why we started coming into intersectionality and trauma-informed. So a lot of times people are like, well, what is intersectionality? So there's this great cartoon by Miriam Dobson. This is Bob. He is a stripy blue triangle, and Bob should be proud. I'm saying, yay, me. But sadly, some people do not like Bob. Bob faces oppression for being a triangle. As you can see, the sign that says down. God hates triangles, and also for having stripes, down with stripes. So but luckily there are some great groups out there, but they aren't intersectional. So you can see welcome triangles, welcome stripes, and they don't talk to each other, they actually compete with each other. And so poor Bob just can't work out where he should go. Am I more stripe? Am I more triangle? And Bob wishes that the triangles and stripes could work together. So oppression of one affects us all, no liberation without equal representation. So intersectionality is a belief that oppressions are interlinked and cannot be solved alone. So oppressions are not isolated. And the concept of intersectionality actually emerged from a number of different theoretical groundings, including US Black feminism, Indigenous feminism, Third World feminism, queer post-structuralist feminism. And the term itself was first officially coined by Kimberly Crenshaw in 1989. So this has been around for a while. Intersectionality promotes an understanding of human beings as shaped by the interactions of different social locations or categories in which they inhabit. So all of those things that we talked about before, race, class, gender identity, gender expression, age, sexual orientation, all of these pieces together. And it's important to remember from an intersectional perspective, when we're talking about social categories, there's 4 pieces to the puzzle. First of all, these categories, gender identity, race, class, they are dynamic. They're considered historically grounded. They are considered socially constructed. And they are considered as working both on a micro level of the self, but also the macro level of systems of oppression. So understanding these is important. And then the interactions between these social categories in which we inhabit occur within a larger context of connected systems and structures of power. So laws, policy, governments, media, public institutions. And through these processes, there's interdependent forms of privilege and oppression that start to occur that are shaped by colonialism, racism, sexism, homophobia, hatred, all those. And to put it more simply, Alina Henskiewski, who is a prominent intersectional theorist, says, according to an intersectionality perspective, inequities are never the result of a single distinct factor. Rather, they are the outcome of different social locations, power relations, and experience. So Audre Lorde, also a prominent theorist, who says There is no such thing as a single issue struggle because we do not live single. So how does this relate to patient and public engagement? The big thing is that, the big thing is the central goals are really the same between patient and public engagement and intersectionality, in that social inclusion of voices that are traditionally less heard is one of the most important pieces of the puzzle. And this is achieved by various ways of looking at things, including conceptualizing social categories as interacting with and co-constituting one another to create unique social locations over time and place. What they typically say is it's like an oscillating web, where we're looking at the intersection. So say if we're looking at the intersection of race and gender identity, it's not actually about the intersection itself, it's about what the intersection tells us about larger systems of power. That's how you can start thinking about it. And it's typically a multi-level analysis, so we're looking at the micro level, so the self, grassroots communities. We're looking at the meso level or the intermediate level, meaning provincial governments and legislation, and then the macro level where we're talking about national policies, legislations, and so on, how those all interact. And so we're looking at how those intersecting processes by which power and inequity are produced, reproduced, actively resist. We take a step further by talking about an Indigenous intersectional analysis. And this is pertinent, I think, when we're talking about incorporating a trauma-informed intersectional analysis within Canada, within patient and public engagement. We need to think about the foregrounding of anti-colonialism, as well as the varieties of Indigenous sovereignty and nationhood aspirations. And though this challenges kind of conventional intersectional scholarship, it's been written that until Canada and Canadian policy actually starts to address the root causes of violence that are embedded both at the discursive and the structural levels of society, that there's a need to ensure and approaches expose those intersecting colonial discourses and practices that continue to be reproduced and reconstituted. So examining the role of colonization, both past and present, in all of our policy systems. And a woman by the name of Natalie Clark does a great job of actually kind of showing what this involves. And it involves 5 big steps. An Indigenous intersectional analysis would first of all include an analysis of research and policy intersections as colonial violence. It would include an anti-colonial gender analysis. It would involve a contextualization of individuals within community and family histories, a positioning of agency, including the capacity to make decisions for oneself as central, and then finally acknowledgement of resistance. So these are important factors when we're talking about engagement. What do we mean by trauma-informed? A lot of people say, well, trauma-informed, I don't quite understand how we integrate that within an engagement piece. So it's an important and often overlooked piece of the practice of patient and public engagement in health research. It's a recognition that the experiential knowledge of the public that's often being sought by researchers when we're doing research decision making can be intertwined with experiences of trauma. For example, evidence shows that in primary healthcare systems, there's significant trauma histories that can come up, which have an impact not only on the health of people, but also on their responsiveness to health interventions, and those pieces as well. And experiences of trauma may also impact an individual's ability to access appropriate healthcare services and hence to even identify as a patient. So we want to start talking about embedding in any type of patient public engagement strategy that you're trying to develop an understanding that, first of all, that trauma is a widespread, harmful, and costly health issue. that that it occurs as a result of violence, abuse, neglect, loss, disaster, war, and other emotionally harmful experiences, and that it's sometimes seen as a universal experience when we're talking about mental health and substance use issues. Also, we need to acknowledge that healthcare systems themselves can often actually be trauma-inducing for people. For example, the use of coercive practices such as seclusion or restraints in behavioral health systems, as well as invasive procedures that are done within the medical health system, can be re-traumatizing for people who may have already experienced significant trauma. So by recognizing the kind of pervasiveness of trauma, we need to start thinking about how we can design engagement strategies that address these types of things. And it's not only, trauma doesn't only live solely with patient and public partners. Health researchers as well sometimes bring to the table their own experiences of trauma. We have the whole concept of the wounded healer paradigm, where people are sometimes attracted to studying certain research issues because they have some experiences. So understanding that piece as well. And understanding that traumatic events often set up a power differential where one entity, so whether it's an individual, whether it's an event, a system, or a force of nature, has power over another. So an individual's experience of these events or circumstances often are shaped in the context of this powerlessness. Feelings of humiliation or guilt or shame or betrayal or silencing. And so that shapes their experience of this event. So it's important when you start to develop interpersonal relationships between patient partners and health researchers that we don't actually reproduce this power imbalance again or these feelings again in any way. So understanding how to have safe spaces. So recognizing that there is a widespread impact of trauma, recognizing signs and symptoms of trauma, and seeking actively to resist traumatization through the creation of both physical settings and interpersonal processes that support safety. And we're going to talk about some of the questions you need to ask yourself to help develop those things. So, an important component of intersectional analysis and the way that we explore power in intersectional analysis is using critical reflexive practice. What does this mean? This means we're actually going to start, both as researchers and patient partners, to explore some of those pieces of our own social identity and how that is associated with larger systems of power and oppression. So some of the questions that we start to ask each other as we come together are, first of all, think about what my own personal values, experiences, interests, beliefs, and political commitments in the area of health will be researching. Now, a lot of times, health researchers think, well, I'm this objective entity coming in. They often say, well, patient and public partners come in with their own set of, they're going to come in and advocate and they have bias. Not true. Both sides bring their own personal values, experiences, interests, beliefs, and political commitments to the table. So we need to start talking about what it is, how this is, and how this may affect what we're looking at. How do these personal experiences that I'm looking at relate to social locations in which I inhabit? So for me, as a white settler, as a cisgender woman, as a middle class, I have to think about how those social locations in which I inhabit and the processes of oppression that exist in the area of health in which we will be researching. So actually starting to think of all of those pieces. And this requires a lot of honesty and a lot of reflexiveness. What are my own personal values, my assumptions, my perspectives, and experiences with regard to the people living with the health issues in which we will be researching? Let's start thinking about that. Oftentimes we make a lot of assumptions about people who we want to engage, and who we're thinking about as far as the research project. Here's the big one, and I feel like patient public engagement cannot occur if we don't think about what current health inequities exist with regard to the area of health in which we will be researching. So when we're developing our patient public engagement plan, we need to think about who experiences the health issue differently, who has different access to the healthcare system, how are we going to ensure that all of these voices are being heard? How do you think people with lived experience would prefer to be involved in research, and why? What types of challenges do you think would need to be addressed in order to make it easier for people with lived experience, as well as their families and communities, to be able to fully contribute and be involved in the research? This means having conversations with people of how they would prefer to be engaged and changing the way in which we do research. How can we become more aware of and take advantage of opportunities where we can challenge each other's ideas and renegotiate power within our research? So this is a good conversation to have, and we need to talk about that. How can we safely say to one another, listen, that's a load of what you're saying right now does not resonate with me, or you're behaving in a way that is very top down, and you need to take a step back. How do we have those conversations? What does resilience look like, feel like, and sound like to you? This is a huge part. When we're talking about trauma-informed, we're talking about looking at things from a strengths-based perspective. Meaning we wanna think about resiliency and communities and patient public partners, recovery, all of these come together. How do you think the issue of trauma may impact the area of health in which we will be researching? I sometimes have people say to me, well, I'm not looking at health research issues around domestic violence. I'm talking, I'm doing research around survivors of cancer. Well, we now know there's lots of evidence around survivors of cancer who have experienced PTSD, so post-traumatic stress disorder. So we need to understand that the healthcare system itself and the experience that patient public partners may go through may have connections with trauma. Let's think about how we're going to ensure that we're not going to do an engagement approach that's going to be re-traumatizing. What do you think are some of the ways in which we can make sure everyone feels safe when we're together on a research project? We're going to get to a little bit of an exercise in a minute on that. There's one other piece of the puzzle that we sometimes don't think about, and that is embodied reflexivity. So a lot of times when we talk about critical reflexive practice, we are talking about discursive reflexivity. And what that just means is it's kind of, we're talking about language and symbolism and systems of power and oppression. When we're talking about embodied reflexivity, we're looking at how a researcher's physical presence and performance can influence patient and public partners' sharing of their experiential knowledge and in terms of production of knowledge. So it's about actually looking at your own materiality and experiences of your own body and thinking about how that interaction can happen. Because we know that a lot can occur in the silence between our interactions. There are a lot of narratives that can occur about bodies. So when we think about illness, or when we think about people who are differently abled, or even when we think about aging sometimes, there's language or there's narratives around the failing body that's in need of fixing. So, or the continued medicalization of different types of bodies. So we need to start understanding how our own physical presence may impact our interaction with people with different experiences. If we're talking to people who are different sizes, if we're talking to different abled, we need to understand what may not be said out loud, but that may exist because of that interaction, and being fully understanding of that. I typically do myself right about now, but we're running out of a little time. Picture myself at Christmas when I was 5. I will try to work this into another presentation. But now on the practical level, at each phase and stage of the research process, how can we start to develop some questions? So when we're at the very beginning, when we're at the framing and prioritizing of the research question, let's start by saying, as a team, what is the research problem that we will be looking at? How did we decide on that research project? Did we involve people, families, communities with lived experience of the health issue and prioritizing the problem? Is there anyone we have not involved who should be involved? What assumptions, and by assumptions I mean beliefs about what causes the health issue, and which populations are most affected, do you think underlie the representation of the health issue that we're going to be looking at? Who do you think is involved in framing and defining the health issue that way? Why do you think they frame the health issue that way? Do you think the way people look at the health issue has changed over time, so historically, or is it different depending on where they live geographically? Is the health issue framed in different ways? What inequities exist in relation to the health issue we will be researching? You did your critical reflexive piece together. Now this is when we're moving into understanding the different populations that we get. Where should we look to find the necessary information to help answer this research question? Sometimes it's not necessarily in the places that we think we should as researchers. Maybe it's talking to communities, maybe it's finding other information outside of that. In what ways do you think we could get a conversation going about the health issue we're researching across different groups of people who may be differently affected by this health issue? So in this way, we're starting to think about maybe using different participatory approaches to have conversations. When thinking of the different groups of people who may be differently affected by the same health issue, what do you think are things that we still need to work at better understanding? What are the knowledge and evidence gaps that we need to address? When we start to think about deciding on our engagement strategy, talking about what roles you think people with lived experience, their families, and communities be playing, what would like to play. How do you think we can make sure that everyone's perspectives are included and that we address inequities as well as issues of social justice while we're at it, our participatory approaches? What can we make sure, how can we make sure when we come together that we're not reinforcing existing stereotypes or biases or reducing further inequities for some people in the population? So what kind of things to ensure? What do you think would be the best way for people with lived experience, their families, and communities to be involved in making sure that outcomes or results of the research actually lead to a reduction in inequities? In what ways do you think we can work together to make sure everyone on the research team, as well as any people involved in the research project, feels safe? So how do we make sure the physical setting that we're meeting in is considered safe by all members? How do we make sure that the interpersonal interactions promote a sense of safety by all? And for that, there's an exercise we like to do sometimes when we come together, and that's just having a conversation about how physical, emotional, psychological, and cultural safety. We have this conversation, we do each one of them, and we say, what does it mean to me? So what does, say, emotional safety mean to me? What does it look like to me? And what does it feel like to me? And in having this conversation, we can start to develop principles, guiding principles for our team when we come together. So sometimes people are going to say, well, it means empathetic listening. It means not interrupting, not talking over top, not using jargon. being understanding, means believing in the resiliency of communities, not making assumptions about us. And so in having this conversation, and it's an ongoing conversation that has to happen on a continual basis, because sometimes it changes, right? Sometimes we notice something in our interaction later on that doesn't make us feel that great. And it's also a great way to, if you have these guiding principles, you can kind of come back to them over and over again. Just as a reminder, remember we talked about this. Remember this is how we define safety. How did the way in which people with lived experience, so we're getting into evaluation. So evaluation. At the end, when we want to evaluate our research project, how did the way in which people with lived experience were involved in the research project help to reduce conflict? How often were there actual opportunities to challenge ideas, renegotiate power within the research project? How were these moments handled when this opportunity arose? How did the research team work together to actively define, address, and ensure emotional, psychological, and physical safety for all research teams? So how did we work on this together? Was there a belief in the privacy of people, families, and communities with lived experience, as well as in the resilience of individuals and communities? Did we use a strengths-based approach? Did we talk about resiliency? Did we respect patient partners? Times that resilience. How did we help? Did the research team understand the importance of differences in power and the way in which certain groups of people historically have not had the same opportunity to voice their concerns, as well as the same choices as other groups of people, and may have received coercive, disrespectful treatment in the health? So was this something that we actually addressed when we engaged? Did the research team make sure to address historical present-day trauma resulting from colonization, patriarchy, racism, heterosexism, and capitalism? Did the research team leverage the healing value of traditional and cultural connection? What? Did the research team actively work to dismantle past cultural stereotypes and bias? Did the research team incorporate policies or protocols and processes that are responsive to cultural needs? And did the research team have access to cultural and gender responsive support services in case a researcher or public partner requires additional support due to past experience? So this is a big one that I always like to say to researchers is, before you do any engagement, do have a resource on hand with a list of possible places that, say, if a patient partner or a researcher is triggered by any of the events, that they can promptly get access to service. And so that means free services, free walk-ins within your community, toll-free lines, and there's just different ones that are culturally responsive as well. So having that list already on hand and making sure that no one ever leaves an engagement without having that resource. Oh my goodness, and we went through all of those questions. So these are all things that we can start to work on and think about as we move forward as a research team when we want to talk about trauma-informed intersectional analysis. So at this point in time, are there any questions now that Rachel, are there any online? No. That's okay. One thing is, you can always email me or tweet me if you ever have a question around this. And I'd be more than pleased to chat with you. about birth. So, lucky you guys. This is the end. This is the last of 2018. But in 2019, our next Lunchtime Learning Series will be Wednesday, January 9th at 12 p.m. Central. And we're actually going to have a case study. So you're not going to have to hear me talk anymore. And that is going to be around community engagement prior to basic science research. This is a really important one, especially for your basic science researchers. We'll have Monica Kowash, who is a PhD student with Dr. Keith Pope's lab here in Manitoba, and she's going to talk about engagement science, which is really exciting, and I encourage everyone to come. So if there is no more questions, I'd like to say thanks for joining us here in the room and online.